A very good morning, my friends and colleagues. This lecture is about ventilator-induced lung injury, and we are going to basically review most of the available literature from past to present on ventilator-induced lung injury in this lecture. So it is going to be a little long lecture. The assignment for this lecture are to discuss fundamental factors of ventilator-induced lung injury like paratrauma, volutrauma, atelectatic trauma, the VILI mechanisms, the stress strain concepts and local stress razors, mechanical power concepts, and some other systemic harmful effects. We are not going to discuss things like ventilator-associated tracheitis or ventilator-associated pneumonia, oxygen toxicity and carbon dioxide toxicity and cardiopulmonary interactions. Otherwise, this lecture will become too long. The concept of possible harm from a positive pressure ventilation is not new. In 1827, Leroy in France, with his practical experiments demonstrated that forcible inflation of the lung could rupture the alveoli, causing emphysema and tension pneumothorax with fatal results. In 1745, John Fothergill suggested that mouth-to-mouth inflation of the victim's lung might be preferable to using a pair of bellows, because the lungs of one man may bear without injury as great a force as another man can exert, which by the bellows cannot always be determined. This was a very interesting statement. In 1939, McLean et al. Found that alveolar rupture leads to gas escaping along the pulmonary vascular sheets towards the mediastinum and consequent pneumomediastinum, subcutaneous emphysema, and pneumothorax. This is a schematic presentation of alveolus and capillary and alveolo-capillary membrane. As we can see, this is alveolar space. This is the epithelial basement membrane. This is type 2 pneumocyte. This is type 1 pneumocyte. So this is also type 1 pneumocyte and this epithelial basement membrane. And this is the surfactant which is produced and which is covering the type 1 pneumocytes. This is the intact endothelial layer of the basement membrane of the capillaries and alveolar macrophages. And when mechanical ventilation starts, then volutrauma, atelectatic trauma, all those things come into play. This leads to flooding of the alveoli with the fluid, denuded basement membrane. So the type 1 pneumocytes are almost practically gone and there is only basement membrane left. You can see there is a necrotic type 1 cells. There are inactivated surfactant type patchy places. There is a thickening of the fluid between the alveolar epithelial basement membrane and the capillary endothelium. So this space, the gap has increased and there is a thickened fluid in between. This is going to hamper the gas exchange, and there is a disrupted epithelium and endothelium barrier. Both the epithelium and endothelium barrier is disrupted. This will lead to migration of the neutrophils and macrophages across this barrier, and this leads to neutrophil influx. Barotrauma, this term itself is basically misleading because the critical variable which leads to the air leak is the regional overdistension and not highway pressure per se. The regional overdistension is the key factor, but it is very difficult or impossible to measure. So what we measure is the limiting inflation pressure, the plateau pressure, the positive end expiratory pressure, the mean airway pressure during mechanical ventilation as a surrogate strategy to limit the overdistension. So schematically, this is the airway pressure. The intra-alveolar pressure can be measured by applying an inspiratory hold. So the plateau pressure represents the airway pressure or alveolar pressure. This is the intrapleural pressure between the parietal and visceral pleura. The lung has a natural tendency to collapse on itself, while the surface tension inside the alveoli contributes to 2/3 of this tendency, and the pulmonary surfactant inhibits this tendency. 1/3 of this tendency of collapse of the lung on itself is because of the elasticity of the lung parenchyma, because of the elastin fibers, while the chest wall around the lung has a natural tendency to expand, and this creates the negative intrapleural pressure between the parietal and visceral pleura. The pressures which we are seeing on the ventilator screen, the plateau pressure, the positive end expiratory pressure, the mean airway pressures, are actually the pressures which are required to distend the lung as well as the chest wall. This we need to remember. So the transpulmonary pressure is the actual pressure which is required to expand the lung and the alveoli, and this pressure is the difference between the airway pressure which is displayed on the ventilator screen and the pleural pressure. So when we apply a zero airflow like inspiratory hold, then we have a situation whereby the pressure which is displayed on the ventilator may represent to some extent transpulmonary pressure. And we can say that the lung volumes and transpulmonary pressures are so much closely linked to each other. So the airway pressure is the pressure which is displayed on the ventilator screen, and the pleural pressure is generally measured through various techniques. One important technique, commonly used technique, is esophageal pressure, which has got its own limitations, but this is not the place in this lecture to discuss about that. So basically, we measure the pleural pressure, we measure airway pressure, take the difference, and calculate the transpulmonary pressure. In a normal spontaneously breathing patient, at the peak of inspiration, there will be a negative pleural pressure of around -8 centimeters of water, and the alveolar pressure will reach zero. It will become a balance with the atmospheric pressure. So the transpulmonary pressure will be 0 minus 8, that is around +8 centimeters of water in spontaneously breathing patient. If there is a chest wall edema, like a thick chest wall because of obesity, ascites, pleural effusion, and in such situation, the pleural pressure will increase. So, for example, suppose it is 25 centimeters of water, and the patient's airway pressure is say to 30 centimeters of water, then the transpulmonary pressure will be 30 minus plus 25, that will be only 5 centimeters of water. We will discuss these things later in our stress and strain part of this lecture. In a patient who's playing a trumpet, the airway alveolar pressure may go as high as 150 centimeters of water. So technically speaking, if your alveolar pressure is 150, it should rupture, you should have pneumothorax, pneumomediastinum. But the important part to remember is their pleural pressure is also high. So their pleural pressure will be somewhere around 140 centimeters of water. And because of the contraction of the diaphragm and the contraction of the chest wall muscles, and this intrapleural pressure, this arrow should be here actually. So this intrapleural pressure will be around 140 centimeters of water. So the difference will be 150 minus 140 with the transpulmonary pressure will be 10 centimeters. So although the alveolar pressure is so high, the transpulmonary pressure will be still 10 centimeters and they are still protected. They don't develop any air injury or barotrauma. Coming to atelectasis trauma is when the alveoli are mostly closed and de-recruited. This atelectasis leads to low FRC, and this will increase the pulmonary vascular resistance, as we all know from our basic physiology, and this will increase the right ventricular afterload. Apart from that, atelectasis is also known to increase the inflammation in the lung and lung inhomogeneity. This was the study by Tremblay et al., which was published in 1997, where they ventilated rats as a control as moderate tidal volume, high PEEP, moderate tidal volume, zero PEEP, and high tidal volume at zero PEEP. And they demonstrated that the inflammatory markers, cytokines, were higher only when the PEEP was zero. So this clearly indicates that atelectasis increased the inflammation. This brings us to the concept of biotrauma, which is the term which underlines the relationship between mechanical stress and strain and the generation of local as well as systemic inflammatory response with increased cytokines. So this is very important that biotrauma is not just restricted to the lungs, but the cytokines which are released from the lungs also spill over to the systemic circulation, leading to multi-organ dysfunction. So the increased physiological dead space which happens, as we already discussed, because of the fluid accumulating between the alveolar capillary membrane and because of the VQ mismatch also, decreased lung compliance which happens, all these things lead to hypoxia and hypercarbia and increased concentration of hydroxyproline, transforming growth factor beta, interleukin 8, release of various inflammatory cytokines like TNF alpha, IL-6, IL-1 beta, and many more, and recruitment of pulmonary alveolar macrophages and neutrophils. All those things will lead to activation of the endothelium and epithelium, and this will ultimately lead to translocation of lipopolysaccharides and bacteria and various mediators. They will cause inflammatory damage within the alveoli, and they will spill over into the systemic circulation also, and this will ultimately lead to systemic inflammation, multi-organ dysfunction, and death. Apart from this, the studies are now showing that the stretch in the alveoli leads to activation of a transient receptor potential cation channel, and this ultimately leads to activation of the vagus nerve. Hypoxemia, hypercarbia, mitochondrial dysfunction, biotrauma, alveolar stretch, All these stimuli ultimately lead to the signals going to the brain, resulting in a breakdown of the blood-brain barrier and damage to the hippocampus. Coming to volutrauma, this is because of the excess amount of volume. Interestingly, this all started from this particular study which was published in 1963. It was done on 18 patients undergoing laparotomy, and it showed that high tidal volume during anesthesia resulted in less atelectasis, less acidosis, improved oxygenation as compared to low tidal volume. And for next 30 years, then all textbooks, articles, practice continued to maintain tidal volume of 10 to 15 ml per kg for these benefits. In fact, in early studies in ARDS also, most of the tidal volumes described were around 10 to 24 ml per kg. In 1996 survey, intensivist ventilation practices for patients with ARDS showed that 50% of the respondents reported using tidal volume of more than 10 ml per kg. This was a landmark article, a study which was published in 1988 by Dreyfus and his colleagues. They found that the pulmonary edema developed in animals undergoing ventilation with high tidal volumes, whereas the edema did not develop in animals undergoing ventilation with similar airway pressure, but with the straps around their abdomen and chest that reduce the tidal volume. So applying high pressure did not cause problem. Only high volume was associated with alveolar edema, and PEEP had some protective effect. Very important study. This was a game changer study, a landmark study in the field of mechanical ventilation. Now the question is, are children less susceptible to ventilator-induced lung injury as compared to adults? As we know, chest wall elastance evolves in children with increasing age. And during infancy, the chest wall is nearly 3 times more compliant than normal lungs. And by the second year of life, the chest wall stiffness increases to the point that the chest wall and the lungs are nearly equally compliant as in adulthood. High chest wall compliance puts the infant at risk of lower end expiratory lung volume by reducing the outward chest wall recoil relative to the inward lung recoil. So, in situations like bronchiolitis or in pneumonia, the infants will augment their end expiratory lung volume by mechanism of grunting, that is using laryngeal adductors and the diaphragmatic muscles. As the chest wall stiffness increases by the age of around 2 to 3 years, this will allow the child to maintain end expiratory lung volume passively. Young infants, after positive pressure ventilation, induce generation of more of elastin fiber as compared to collagen fiber, and this will also have an implication on healing in the lungs, because more elastin fibers are more healing friendly as compared to collagen fiber. Moreover, the studies have also shown that higher tidal volume generates more surfactant production in infants, and surfactant production is more helpful because it is more anti-inflammatory and lung protective. This was the first study which was actually comparing infants versus healthy adults, rats, by Copeland and co-workers, which was published in 2004. And they studied the cytokine expression, and they found that compared to adults, newborns had a significantly lower level of cytokines, and that means the ventilator-induced lung injury was lesser in infant lungs compared to adult rats. Now, the question was, they used with tidal volume normalized to body weight. So they used tidal volume per kg body weight. And the question was whether it is correct, because the approach makes sense as a means of normalizing tidal volume as long as the lung size is proportional to body weight. But the relationship of the lung volume and the body weight greatly varies in immature and mature lungs. The FRC to body weight ratio averages to 47 ml per kg in newborn rats compared to 13 ml per kg in adults. So this ratio of FRC to body weight is significantly higher in newborns compared to adults. So if you take 6 ml per kg for a newborn, that 6 ml per kg will be lower for that newborn as we take FRC to body weight ratio compared to an adult 6 ml per kg. So that comparison may not be correct. In addition, the ratio of total lung capacity to body weight is also significantly larger in infants as compared to adults. So, as we can imagine, the lung stresses would differ between infants and adults if we just normalize tidal volume to body weight. This was one more very important study, a landmark study, which was published by Kornicki et al. They ventilated 60 minutes rat lungs at high tidal volume, and they found that infants' lung may be less susceptible to ventilator-induced lung injury when exposed to comparable ventilation settings of tidal volume or pressure. They demonstrated that the way the infant lungs and the adult lungs behave at different inspiratory and expiratory pressures are different. The end inspiration alveolar size appears more uniform in infants compared with adult lungs, and hence when we are applying a positive pressure, a positive end expiratory pressure like PEEP, or when we are applying a recruitment maneuver, we can imagine that the infants will behave differently as compared to adults, and hence we need to be very careful when we are extrapolating literature of recruitment maneuvers and PEEP titrations from adult literature to pediatric age group. Again, the data from Kornicki et al. Can be subjected to the same criticism as Copeland study because they also took tidal volume normalized to body weight. However, Kornicki et al. They used the tidal volume normalized to baseline total lung capacity. So they set the tidal volume to 50% of the total lung capacity. So this was kind of adjustment for that particular query which was raised for Copeland study. Now, we all know the high tidal volume is injurious in adults, but is the same thing clear for the pediatric age group also? Well, the literature is very sketchy. There are so many studies which did not support the evidence of high tidal volume being associated with mortality in pediatric age group. These are some examples. And there are some studies which are supporting the evidence that high tidal volume may be actually beneficial because it promotes surfactant production and anti-inflammation properties of surfactant. The next question is the tidal volume, whether it should be calculated as per body weight, actual body weight, or as per the ideal body weight in children. For this, I can share two studies. This was one retrospective study of 483 children, and they found that tidal volume in ml per kg was higher when used ideal body weight, particularly for overweight and obese children. And tidal volume of more than 10 ml per kg was associated with poor outcomes. This was more important. There was a study which was published recently. I think it was published in 2018, and again a retrospective study. And they found that obese children have lung volumes reflecting their predicted body weight from height, while children with low or normal body mass index have lung volumes reflecting measured body weight. So what it means is that if you have an obese child, it is better to use predicted body weight. While if you have a normal weight or a malnourished child, it is better to use actual measured body weight to prevent problem of excess amount of tidal volume delivery. So now we'll come to various lung protective ventilatory strategies, and we will look at those strategies based upon some very important pivotal studies. The journey started from 1973 from Biotrauma, then Volutrauma. We already discussed about the Dreyfus study in 1988. Then Atelectrauma also we discussed in 1997, and then we will go through the journey of ergotrauma, etc. ARDS was first described by Ashberg et al. In 1967, and he observed in that study also that PEEP improved oxygenation, although it did not improve the survival. This was a very small patient cohort of only 12 patients, and this was the landmark paper where ARDS was described for the first time. Concept of barotrauma, volutrauma, which we discussed already, this in 1970s and 80s led to the development of lung protective ventilatory strategy. The concept of ventilating at lower tidal volume, higher PEEP, attempt to prevent atelectrauma led to open lung approach. One study which I can quote is in 1998, before our famous ARMA trial was published. This was by Amato et al., a randomized controlled trial, where they compared PEEP titrated above the lower inflection point of PEEP pressure volume loop, and then considered conventional way of using minimal PEEP. So the minimal PEEP was just around 6 to 7 centimeters of water, and they used PV loop lower inflection point, and they demonstrated the beneficial effect of using PV loop. They showed that when you titrate the PEEP as per PV loop, then the survival is better. The second study which I can quote in that era, which was in 1999 from Ranieri et al. Again, they used the PEEP titrated as per PV loop, pressure volume loop, and this PEEP was around 14.8 centimeters of water for 7.6 ml per kg of tidal volume, and it resulted in significantly lower concentration of inflammatory markers. And these are the two important studies which were already done before this very famous and very well-known ARMA trial or ARMA trial, which was published in year 2000. This study was comparing 6 ml per kg tidal volume. At that time, it was considered as low tidal volume versus the conventional or traditionally used tidal volume. At that time, it was traditional, but it is high actually. So that was 12 ml per kg tidal volume. It was a multicentric randomized control trial. The low tidal volume group received 6 ml per kg of predicted body weight, and they kept blood pressure less than 30 centimeters of water. While the traditional tidal volume, at that time it was considered traditional, that was 12 ml per kg of predicted body weight, keeping blood pressure less than 50 centimeters of water. They used PEEP FiO2 table. It's a different story how they arrived at this PEEP FiO2 table. We can discuss at some other occasion. So they used this table and titrated the PEEP based upon the oxygenation. If you look at the baseline characteristic table, the patient's population was comparable. The conclusion of the study was in children with acute lung injury and acute respiratory distress syndrome, the low tidal volume was better in terms of mortality and increased number of days without ventilator use. But if you look closely, the low tidal volume group versus high tidal volume group, in high tidal volume group, that is, at that time it was considered as a conventional tidal volume, of course. So 12 ml per kg tidal volume group, we can say, had a significantly higher blood pressure of around 50 centimeters of water, which is a problem because naturally this is harmful. And also the positive end expiratory pressures were also higher on day 1 and day 2 in low tidal volume group as compared to high tidal volume group. So was that higher PEEP protective, and did that affect the outcome of the patients? To answer this question, the alveoli trial came after another 3 to 4 years. I think it came in 2004, and this alveoli trial compared two FiO2 tables, the low PEEP FiO2 table and the high PEEP FiO2 table. The objective was to ventilate both the groups at same 6 ml per kg tidal volume and keep the blood pressure less than 30 centimeters of water, and compare these two tables. And they found there was no mortality difference between the high versus low PEEP strategy. And this important thing emphasizes the importance of low tidal volume and low blood pressures. So if you keep your blood pressures below 30 and tidal volume of 6 ml per kg, the high PEEP versus low PEEP doesn't matter. This was the important finding in this study. So between 2012 up to 2014, everybody was ventilating at 6 ml per kg of predicted body weight or measured body weight, hoping that all the lung is like this, homogeneous, nicely, and just push 6 ml per kg into this lung. However, as we know, truth can be stranger than fiction. In patients with ARDS, lungs can be like this, and it can be completely inhomogeneous lung with very few amount of lung or baby lung available. And if you just push 6 ml per kg of tidal volume in this kind of lung, you can imagine there's no space, and there will be a problem. There will be a lot of injury to the lung because of excess amount of volume in small capacity of lung. And hence the landmark article of Amato et al. Came in 2015, which actually hypothesized that instead of taking tidal volume to predicted body weight, better to titrate tidal volume to available respiratory compliance or baby lung, and as an indication for functional size of the lung. And they termed this ratio of tidal volume to respiratory compliance as driving pressure, which can be at the bedside measured as a difference between blood pressure minus PEEP. So this is your PIP, P plateau, and driving pressure is the difference between blood pressure minus PEEP when the patient is not breathing spontaneously, I mean there is no auto PEEP. So what they demonstrated was, if you keep the same PEEP and you allow the driving pressure to rise, and your blood pressure also going above 30, the mortality is increasing. If you keep same driving pressure and allow the PEEP to rise, or even blood pressure going maybe beyond 30 also, but if the driving pressure is constant, there is not much change in the driving in the mortality. However, if you titrate your PEEP nicely, you keep the blood pressure below 28 centimeters of water, and the driving pressure is reducing, then you will see that a reduction in the mortality happens. So this particular point is very, very important. That means when your titration of the PEEP is happening with reduction in driving pressure and keeping blood pressure less than 28, you are basically going to see improvement in the outcome. The ARMA trial is often viewed as showing that low tidal volume decreased the mortality from ARDS. But we can see from Amato that it was not just the low tidal volume which was improving the survival. but the survival improved only when large change in the driving pressure were avoided, and it was not just the low tidal volume, but it was keeping the driving pressure safe and keeping the plateau pressure below 28 centimeters of water. In pediatrics, this was an important study which was published in 2021. It is a retrospective study of 222 children where they found higher driving pressure to be significantly associated with time to extubation. They also compared the ratio of the tidal volume to respiratory compliance and correlated with the two equations, plateau pressure minus PEEP and dynamic driving pressure, that is PIP minus PEEP. And they found that the plateau pressure minus PEEP correlated better with actual driving pressure of QT divided by CRS. And they found that dynamic driving pressure, that is PIP minus PEEP, actually overestimated driving pressure because of the component of airway resistance. This was another study in 2021 which showed that even in a normal lung, if you keep driving pressures above 12 centimeters of water, it can cause harm and is associated with probability of causing ARDS. Driving pressure is still not validated in pediatric age group. Hence, the safe threshold is around 12 to 14 centimeters as taken from the adult studies. In normal lungs, it is better to keep it below 12 centimeters of water. And in children with pediatric ARDS, better to keep below 15 centimeters of water as per the recommendation by the PALIC 2. This is an interesting paper which was published by Paulo Pelosi, where they studied the effect of driving pressure, effect on driving pressure and the stress index of the application of same tidal volume on lungs with different characteristics. So in this example A, when there is a very severe problem of lung compliance and there is severe loss of aeration and poor recruitment potential, the tidal volume distribution will be small and very high driving pressure and high stress index will be seen. While in example B, where there is some improvement in the aeration in the lung, you will see that driving pressure will still be high, but it will be lesser than example A, and stress index also will be high, but it will be lesser than example A because tidal volume delivery is better now. And in example C, you will see there is a modest loss of airway. So good driving pressure in safe zone, stress index also in safe zone. And then the other extreme in example D, when there is hyperinflation, air trapping, and this again leading to excess amount of driving pressure and excess amount of stress index. So we can see that when the compliance is improving, the tidal volume can be higher and it can be better accommodated. In other words, the driving pressure and stress index will be lower when the compliance is higher. So in a situation where you have suppose a PEEP of 8 and a plateau pressure of 22, your driving pressure is say 22 minus 8 of 14. And in a patient, suppose you increase the PEEP from 8 to 12, your plateau pressure has increased to 28. Now your driving pressure is 28 minus 12, which is around 16, which is harmful, which is above 15. But if you have suppose a recruitable lung, then the same PEEP of 12 will lead to improvement in compliance. And improvement in compliance means for the same PEEP of 12, you will have a plateau pressure of 22 instead of 28 and driving pressure becoming 22 minus 12, that is 10. So in a recruitable lung, when you increase the PEEP from 8 to 12, you see there will be a fall in the plateau pressure in volume control mode, of course, and you will see a fall in the driving pressure. And in a non-recruitable lung, you will see plateau pressure going up and you will see the driving pressure also going up. So in a normal lung with normal compliance, higher tidal volume can be accommodated, driving pressure and stress index will be lower. And in poor lung compliance, the tidal volume will be lesser accommodated and driving pressure and stress index will be higher if you try to give more tidal volume in such a lung. So what we are learning from these examples is that driving pressure should be monitored considering what tidal volume you are pushing in the lung and what is the available lung compliance. So basically, driving pressure is a tool to titrate tidal volume for the available lung compliance. Many times we see the students talking about driving pressure as a tool for titration of PEEP. Well, it can be used for titration of PEEP, but primarily driving pressure is a tool for titration of tidal volume for available respiratory compliance. And when you are using driving pressure for PEEP titration, we should have to be very careful to watch against what PEEP you are applying that driving pressure, because you can have a safe driving pressure of only 10 or 12 centimeters of water, but if the PEEP is zero, or if the PEEP is say very high PEEP of 10 or 12 or 15, then it can be harmful. So under at what PEEP that driving pressure is applied, and what is the underlying lung compliance, and what is the delivered tidal volume or targeted tidal volume, all these things you need to consider before you are basically using driving pressure for titration of PEEP. Lung safe study was another important study which was published in 2006, international multicentric prospective cohort study, which was done in a window of 4 weeks during winter season of adult age group receiving NIV or non-invasive ventilation, with the patients diagnosed of ARDS using Berlin definition. 459 patients were participated. Important finding in this study for our talk of today is 2/3 of these patients fell within the limit of lung protective ventilation. So they had, we can see the tidal volume of less than 8 ml per kg and plateau pressure of less than 30 centimeters of water. So very good. Most of them were following lung protective ventilator strategy. And we also saw in this study that the patients who were falling into mild and moderate categories received the tidal volume of higher of more than 8 ml per kg. This was also an important finding in this particular study. There was a follow-up study on lung safe data, which was published in same year, in 2016, and they showed there was a linear increase in mortality when driving pressure went above 15 centimeters of water, and also higher driving pressure was associated with mortality in moderate and severe ARDS and not in mild ARDS. When all these things were going on between 2004 to 2012 about lung protective ventilation and using low tidal volume and uh, keeping the blood pressure less than 28, in the other side, there was another thing going on, that was the emphasizing or highlighting the importance of chest wall elastance or stress and strain concept. So this was a very important study which was published in 2004 by Gattinani and his colleagues, where they found that if you have a normal lung elastance to chest wall, a total elastance ratio, like then suppose you are applying a pressure, airway pressure, plateau pressure of say 30 centimeters of water, you will see that 25 centimeters will be used up in opening the lungs, and only 5 centimeters will be used to expand the chest wall, and your transpulmonary pressure will correspond to somewhere around 21 or 22. So this is somewhere safe situation. But if you have a situation where you have a chest wall edema, obesity, or ascites, and in that case, your lung elastance to total elastance ratio is only 0.2, and you have a 30 centimeters of plateau pressure, in that case, you will see 15 centimeters is only used. 15 centimeters of water is used for expanding the lung, and remaining 15 centimeters is used to expand the chest wall. So half of the energy is wasted in overcoming the chest wall elastance, and the transpulmonary pressure will be only 6 centimeters of water. Again, a landmark study which was published in 2008 by Chibula et al. Over 80 patients from different clinical situations, post-surgical, medical, ALI, ARDS, which underwent PEEP trial at 5 and 15 centimeters of water at 4 different tidal volumes. Transpulmonary pressure was measured by using esophageal pressure, and strain was calculated by taking the ratio of tidal volume to FRC equation. They found that these pressures, airway pressures, which are displayed on the ventilator screen, actually did not correlate with the transpulmonary pressure, which is actually measured using the esophageal pressure monitoring or stress. So the airway plateau pressure of 30 centimeters of water corresponded to the transpulmonary plateau pressure of hardly 8 centimeters or 10 centimeters of water to as high as 28 centimeters of water. There was hardly any correlation. This brings us to this concept of stress and strain. So stress is basically when the ventilator is exerting the pressure on the proper lung, the alveoli, the fibers of the skeleton, and there is a equal and opposite pressure, that is tension. Transpulmonary pressure is also known as stress, which is the difference between the airway pressure and pleural pressure, as we already discussed. While the strain is the changes which happen in the lung in response to that stress, that is change in the volume as compared to the initial volume. So this is the capillary endothelium, this is the type for collagen, and this is the alveolar epithelium. And when the same as schematic presentation, so when there can be a stretch on the system from the lumen of the capillary endothelium, or there can be mechanical ventilation leading to a stretch and strain from outside, from the alveolar side also. So this will ultimately lead to unfolding of the plasma membrane, increase in the plasma membrane intermolecular distancing, intracellular lipid trafficking to plasma membrane, or ultimately the plasma membrane stress failure. These are various mechanisms which have been described when there is an application of stress. So there are channels, ion channels, which ultimately get disrupted because of this stress and strain, and there is a destruction of the cytoskeletal structure on the plasma membrane surface. Studies have actually found that when the transpulmonary capillary transmural pressures in the capillaries exceeds 45 to 50 centimeters of water, there is a steep increase in the number of breaks per millimeter. Same thing in these three studies. You can see when the transpulmonary pressure is exceeding 45 to 50 centimeters of water, there is a steep increase in the number of breaks in the electron microscopic field. So the strain and stress, they are correlated with each other. Stress is equal to K multiplied by strain, where the K is the lung specific elastance and strain is basically tidal volume divided by FRC. FRC is the baseline volume and tidal volume is the change which happens on the top of the FRC. So if you have a situation where you have a so-called safe tidal volume of 6 ml per kg in one patient at a certain FRC, and in the same patient, suppose you applied a good recruitment maneuver or a PEEP titration, and you increase the FRC. Now, the tidal volume is same at 6 ml per kg, but the FRC has improved with your recruitment maneuver or your appropriate PEEP titration. And you can look at this equation. You have increased the FRC, that is denominator of the equation. That means the strain is going to reduce, and the stress also eventually mathematically will reduce. So the same tidal volume with better FRC or higher FRC will have lesser strain and lesser stress. So at 0 PEEP, you have a certain FRC and you have a certain tidal volume. And then when you take the ratio of tidal volume to FRC, you have a dynamic strain. The total lung capacity is roughly 2.5 to 3 times the FRC. And when you apply a certain PEEP, you are basically introducing a certain PEEP volume. And then you have an expiratory lung volume. You have VT or tidal volume plus PEEP volume divided by FRC and getting global strain with this. You have an inspiratory lung volume, and these are very good characteristics of a good PEEP. So a friendly good PEEP or optimum PEEP is a PEEP which has introduced a certain PEEP volume and causes alveolar recruitment, and at the same time it is keeping end inspiratory lung volume safely away from total lung capacity. So it's a win-win situation and good for the lungs. Protti et al. Ventilated 29 patients. This study was published somewhere in 2011, and they found that the features of ventilator-induced lung injury developed only when the strain was exceeding 1.5 to 2. The pigs with the strain below 1.5 actually survived. So this means that when the transpulmonary pressure was somewhere around 24 centimeters of water, it was corresponding to a strain of around 1.5 and between 1.5 to 2, you can say. So this is histopathologically also correlating with the features of biotrauma and volutrauma. So most of the times, if your chest wall elastance is normal, a transpulmonary pressure of 24 will correspond to blood pressure of around 28 to 30 centimeters of water. So if you can't measure transpulmonary pressure directly, and if your chest wall elastance is normal, if there is no obesity, ascites, pleural effusion, chest wall edema, then you can just keep your blood pressure below 28 or 30 centimeters of water and assume that your transpulmonary pressure is less than 24 or your strain is below the danger zone. In another study by Protti et al. In 2015 on 76 pigs demonstrated that ventilator-induced lung injury was more likely when the threshold for the inspiratory capacity was breached. So this was very important. That means when there is an excess amount of PEEP and your end inspiratory lung volume is touching the total lung capacity, there is more chance of volutrauma. So suppose you are having a respiratory rate of 30 per minute, that means 30 times every minute you are hitting the total lung capacity, leading to more and more lung injury. Thus, an optimally applied PEEP may prevent ventilator-induced lung injury when tidal volume is lower, when higher PEEP can be harmful, when the global strain increases and pushes the lung to total lung capacity. So, with all these things, now we can assume that in a lung, we can have baby lung, where the lung is ventilated at end expiratory lung capacity, end expiratory lung volume, that is FRC plus PEEP volume. We can have a recruitable lung, where the alveoli, which were previously closed, will open and then remain open during inspiration as well as expiration. And this is healthy. This will improve oxygenation and carbon dioxide removal and improve lung compliance. And you have a non-recruitable lung, where the lung is totally non-recruitable. Either the alveoli will not open at all, or they will open at a very harmful PEEP, where you are reaching the total lung capacity and cause very significant hemodynamic disturbance and volume. So PEEP can be selected based upon oxygenation parameters like PEEP FiO2 table, as we already discussed, the ARTSNet trial, the alveoli trial, or PEEP can be also selected based upon pulmonary mechanics like pressure volume loop, lung compliance, driving pressure, and plateau pressure. The ARTSNet study, as we discussed, an alveoli trial also recommends a PEEP FiO2 table. PILIC 2 also is now recommending PEEP FiO2 table, but as you know, it is recommending very high FiO2. So for a FiO2 of 0.7, the PEEP is 14. So that is very high for that particular oxygenation. In fact, the recently published pediatric studies, this was in 2020, this was in 2022, this was in 2021. All these pediatric studies published in good journals, peer-reviewed journals, are showing median PEEP of only 6 to 7 centimeters of water in pediatric age group. So pediatric age group are not using this kind of PEEPs which are recommended by PILIC 2. In fact, if we go back in 2005, Grasso et al. Applied lower and higher PEEP strategies in 19 patients, and the 9 recruiter, that is the patients with recruitment potential, higher PEEP resulted in significant alveolar recruitment and reduction in the lung elastance, that means improvement in lung compliance. While in the 10 non-recruiters, the alveolar recruitment was minimal, oxygenation did not improve, lung compliance also worsened. So, increase in oxygenation and uh, reduction in the static lung elastance, or improvement in the compliance and shape of the pressure volume loop during lower PEEP strategy were independently associated with lower alveolar recruitment. This was a study published in 2005, as we can imagine, and they had already noticed that. And they concluded that the PEEP FiO2 table, which was proposed by ARTSNet, lacked the solid physiological basis and frequently failed to induce lung recruitment, may increase the risk of alveolar overinflation. Coming to 2008, this EXPRESS trial, again a very important study, they had done this RCT in 37 ICUs, 767 adult patients. They had 2 groups, the minimum distension group, where 6 ml per kg tidal volume and PEEP and plateau pressures were kept as low as possible. PEEP was around 5 to 9 centimeters of water. When the plateau pressure was about 28 to 30, they reduced the tidal volume first and then even reduced the PEEP to maintain the plateau pressure below 28. And when oxygenation fell below the target, the PEEP was increased. While increased recruitment strategy group, the PEEP and plateau pressures were set as high as possible, achieving plateau pressure of 28 to 30 centimeters. Important thing to note was they did not do any recruitment maneuver. They titrated PEEP based upon plateau pressure. So, regardless of effective in oxygenation, in contrast to the PEEP FiO2 scale, they just looked at plateau pressure. They found that there was no change in the mortality, although increased recruitment strategy group had better oxygenation. But oxygenation does not mean that patients should improve. The unique feature, as I already said, in this trial was the PEEP titration was based on plateau pressure target of 28 to 30 centimeters of water, and not the recruitment maneuver or PEEP FiO2 table. So the outcome of this EXPRESS trial can be compared with the results which we already discussed, the Amato study, which was published in 1998, and the Ranieri et al. Study, which was published in 1999. In those studies also, they had chosen their PEEP based upon pressure volume loop, and then they found that there is an improvement in outcome. While the alveoli trial and ARTSNet trial used the PEEP FiO2 table, and particularly alveoli trial using PEEP FiO2 table and same tidal volume and pleural pressure did not find any significant difference in the favor of high level of PEEP. ARC trial in 2017, again a multi-centric randomized control trial. They had adult patients with moderate to severe ARDS and a control group who continued to receive low P502 table, and the intervention group were subjected to recruitment maneuver followed by PEEP titration during decremental PEEP, and they found that there was increased 28 days mortality in the recruitment group with an established low PEEP strategy as compared to. So the strategy of lung recruitment and PEEP titration, according to the respiratory system applies, increased the 28 days mortality compared to an established low PEEP table. So this was important. Some patients with limited ability to recruit alveoli, that is non-recruiters, may receive higher PEEP levels unnecessarily because the oxygenation is not improving, so you go on increasing PEEP although the lungs are not recruitable, and these higher PEEPs may be deleterious for those patients. This again underlines the fact that the PEEP table, which was recommended by ARTS group, frequently fails to induce alveolar recruitment. Now, another meta-analysis which was published in 2017 have similar finding. The authors did not find any significant benefit for the use of higher PEEP versus lower PEEP strategy in improving mortality, paratrauma, anything. However, they found that higher PEEP improved oxygenation as measured by the PF ratio. So we can see that application of PEEP is increasing end-expirator lung volume. It is improving oxygenation some and even lung compliance sometimes, but it is actually not improving the outcomes. So the application of PEEP, increasing end-expirator lung volume, improving oxygenation, and sometimes lung compliance without actual alveolar recruitment is called as tidal recruitment. This is called as concept of tidal recruitment. So how come is it possible that you improve oxygenation but still not improve the outcome? So in a non-recruitable lung, when you apply a recruitment maneuver or you increase the PEEP, the intrathoracic pressure will increase and will reduce the right ventricular output. And this will reduce the blood flow through the shunts and thus reduce the venous admixture. This is one hypothesis for improvement of oxygenation. And second hypothesis is Henry's law. So Henry's law is basically when you reduce the mean airway pressure, the partial pressure of all the gases will reduce. When you increase the mean airway pressure, the partial pressure of all the gases will increase. So when you are increasing the PEEP, basically you are increasing the partial pressure of oxygen also automatically. So what is a tidal recruitment? When you have a non-recruitable lung and you are applying a PEEP, ELV will increase due to overinflation of previously open alveoli. Those who are previously collapsed will still remain collapsed. This is one example of tidal recruitment. Or another possibility can be when you apply a PEEP, the end-expirator lung volume will increase with an improvement in compliance also. Why the compliance is improving? Because the alveoli are opening during inspiration and contributing to improvement in compliance. But during expiration, they are again collapsing and they are shutting down. So this is also tidal recruitment. But true alveolar recruitment means alveoli which were previously collapsed should open and they remain open during inspiration as well as expiration. That is true alveolar recruitment. And ultimately, this should improve the compliance, improve carbon dioxide clearance, and improve oxygenation. All the three things should satisfy for an alveolar recruitment. So if your only compliance is improving or only oxygenation is improving, but your gas exchange is not improving, then you don't call it alveolar recruitment. You need to have alveoli which are previously opened. They should remain open during inspiration and expiration with better carbon dioxide clearance and better oxygenation. It is also important to note that even after so-called good alveolar recruitment, ultimately the gas exchange, that is oxygenation as carbon dioxide clearance, will depend upon the perfusion of the recruited lung. So hemodynamics is also important. Good lung perfusion is also equally important. So we see that VILI can be minimized by optimizing the strain, that is optimized PEEP and tidal volume against available FRC, optimizing the stress, the transpulmonary inspiratory pressure, transpulmonary expiratory pressure, and transpulmonary driving pressure. And all this applied at a certain respiratory rate and gas flow. So it is not only about pressures, it is about so many things, the tidal volume, the respiratory rate, and the flow. So this concept of unifying the pressure and non-pressure factors which are causing energy load and multiplying them by respiratory rate and expressing them in the form of joules per unit of time is basically the concept of mechanical power, which was introduced to us by Luciano Gattinoni in 2016. And this particular equation was given to us on volume control mode. So it has got three components: the elastic component, the resistive component, and the static component. A separate lecture will be warranted to explain this. I will just briefly explain the concepts here. So all these things are when multiplied by respiratory rate, then you get mechanical powers, which is expressed in joules per minute. This is basically ergotrauma. So it denotes the relationship between mechanical energy delivered to the respiratory system at each breath and ventilator-induced lung injury. The advantage is obvious. You are basically able to differentiate various components like tidal volume, respiratory rate, airway pressure, positive and expiratory pressure, IE ratio, flow, and you can actually anticipate effect of various components on the lung injury. And the studies actually have found that tidal volume, flow, and driving pressure has got maximum impact on mechanical power, where PEEP has least impact of mechanical power. So as per the ARTSNet study, which they showed that you reduce the tidal volume, or as Drider Dilfus also said, you reduce the tidal volume and you reduce the lung injury. So what we are doing is, when you are reducing the tidal volume, you are basically reducing mechanical power significantly. But the studies also have found that when you reduce tidal volume, there is atelectasis. So to prevent atelectasis, you increase the positive end expiratory pressure, that is PEEP. So when you do that, you prevent atelectasis, but you are not going to increase mechanical power that much, because impact of PEEP on mechanical power is far less as compared to the impact of tidal volume or flow or driving pressure. So this is a good bargain, and this is how we can explain how low tidal volume and high PEEP strategy helps in patients with ARDS. Coming to the duration and rate impacting the mechanical power, a very important study which was published in 2019 demonstrated on these injured rats, where they ventilated over for 2 hours. The control group was ventilated at 6 ml per kg straight for 2 hours. The no adaptation group was ventilated at 6 ml per kg for 1 hour, and suddenly the tidal volume was increased to 22 ml per kg and ventilated for next 1 hour. The short adaptation time group had a ventilation of 6 ml per kg for 30 minutes, and then slowly tidal volume was increased over next 30 minutes. So short adaptation time was provided, and then ventilated for 22 ml per kg for next 1 hour. And longer adaptation time group, right from 0 hour, the tidal volume went on increasing. So very long period, they were exposed to higher tidal volume. Finally, in the last 1 hour, they were given 22 ml per kg of tidal volume. And it was found that no adaptation time and longer adaptation time had significantly higher ventilator-induced lung injury. So this means that if you are having longer duration of exposure to higher tidal volume, you will have more possibility of lung injury. Similarly, the strain rate also results in threefold increase in the prevalence of pulmonary edema. So the strain that were safe at low rates can become unsafe when the same strains are provided at higher rate. That means the lung injury is more at higher rates and longer duration by weakening the stress bearing and micro elements, not allowing enough time for recovery. So the energy to distend the lung, to move the gas, and to keep the lungs alveoli open, when they are multiplied by time, it impacts the injury. So respiratory rate has such a powerful impact. This is so important. So each component of mechanical power, depending upon the underlying clinical condition and the ventilator settings by the physician, can cause ventilator-induced lung injury or ventilator-associated lung injury at higher rates and longer duration. Same thing applies for driving pressure also. So you have this driving pressure, which is not just the driving pressure at one point in time, but it is the cyclical swings which are basically going to cause more and more harm. So at a higher rate, the same driving pressure will be more and more harmful. Mechanical power can be measured by different equation. In pressure control mode, Becker's equation is used. In volume control mode, Catenoni's equation is used. The extended equation is the this equation. Surrogate equation is Gioza's equation for volume control mode. Surrogate equation means you don't need to stand at the bedside and apply inspiratory hold. And here also in pressure control mode, the surrogate equation is Becker's equation, while the actual equation like Gattolini's equation in volume control is the Meshdin equation, which is in pressure control mode. This was a study from two analysis of two RCTs by Guerin et al. And they showed that driving pressure of more than 15 and mechanical power of more than 12 joules per minute was associated with the harm, and less than those threshold was associated with survival. Serpanito study showed a cutoff value of mechanical power of 13 joules per minute. But there are important things to remember in pediatric age group. As we know, in pediatric age group, as the age increases, respiratory rate reduces and tidal volume increases. And naturally, you cannot have the cutoff values of Serpanito and Guerin et al., which can be applied in pediatric age group, because in pediatric age group, mechanical power will be different at different age groups. This was actually demonstrated by Martin Neighbor in 2020. As the age increases, the mechanical power increases. And in their study, they proposed the term mechanical energy. So what they did was they removed respiratory rate from the equation, and they normalized tidal volume to body weight and calculated mechanical energy, and found that mechanical energy does not change with age. But the problem in this is they have removed respiratory rate, and as we already saw, respiratory rate is such a powerful factor, such a powerful component of mechanical power equation. The strategy of normalizing mechanical power to body weight solves one point, that change of tidal volume with respect to age can be sorted out, but still the confounding factor of respiratory rate remains. This was Bhalla et al. Study, which was published in 2022, a retrospective study on 306 patients. They calculated mechanical power in volume control mode using simplified Gattolini equation. Here they took PIP actually instead of P plateau, and they used Becker's equation for pressure control and PRVC mode, and MP was normalized to body weight. And they found that the higher mechanical power, that was mechanical power normalized to body weight, was associated with fewer 28 days ventilator-free days after controlling for confounding variables. Higher mechanical power was not associated with higher intensive care unit mortality, but was associated with higher mortality after removing those children who died due to neurological reasons. Coppola et al. Recommended using mechanical power normalizing to respiratory system compliance as one option, apart from normalizing to body weight. And this is our study, which we recently published in Frontiers in Pediatrics. And again, a retrospective study in 185 patients, children with pediatric ARDS. They were all on pressure control mode. We calculated mechanical power in pressure control using Becker's equation, mechanical energy by removing respiratory rate and normalizing tidal volume to body weight. And we also normalized mechanical power to respiratory compliance. And we found that the mechanical energy at 24 hours was independently associated with mortality. However, after adjusting to the type of ARDS, it was not independently associated with mortality. We also found that only mechanical power normalized to respiratory system compliance at first 4 hours as well as at 24 hours was significantly correlating with 28 days ventilator-free days. And after adjusting for malnutrition, only mechanical power at 24 hours was found to be independently associated, thus highlighting a crucial role of malnutrition. So lungs can be protected by optimizing the driving pressure and ensuring the optimum respiratory rate and duration, and trying to increase the lung homogeneity. That is very important. And lung homogeneity is a very important aspect of ventilator-induced lung injury because of the presence of stress raisers. In fact, as early as in 1970, Mead et al. Showed that at the junction of collapsed alveoli and hyperinflated alveoli, the surrounding areas of atelectasis region, when you are inflating the lung, the pressures can go as high as 140 centimeters of water when the transplant pressure is applied of 30 centimeters. So when you're applying a transplant pressure of 30 centimeters, the pressures around the atelectatic alveoli can be, the stretch pressure can be as high as 140 centimeters of water. So this is very important, and these stress raisers ultimately are present at the recruitable areas of the lung, and they can create very high amount of stress in the lung. The important also part is the amount of availability of recruitable areas are also found to be important for absorbing the mechanical energy. So if you have a higher recruitable lung, that part of the lung will absorb more mechanical energy, less ventilator-induced lung injury. When you have a less amount of recruitable lung, then you will have less area available to absorb mechanical energy and higher chances of ventilator-induced lung injury. The best available maneuver to encourage lung homogeneity is prone positioning. You can see here the consolidation at the dependent area, and after proning, so much improvement in the lung inhomogeneity. The lung has become homogeneous. While you can see in this example, there is so much atelectasis and consolidation, and even after applying a PEEP of 15, there is hardly any change. So only applying a high PEEP won't change much, but just keeping in prone position helps so much. This was an interesting study which was published in 2021, where they showed that the pleural pressures were higher in prone positioning, and therefore transpleural pressure decreased at every PEEP in prone positioning, and prone positioning reduced the pleural pressure gradient and made the lung inflation more homogeneous between dependent and non-dependent areas. And PEEP maintains lung homogeneity at most levels only during prone positioning. Coming to the last part of my talk, and a very important part is impact of spontaneous breathing. So when the ventilator-induced lung injury is so harmful, why to intubate patients? Keep them on HFNC or use NIV, and just to get rid of ventilator-induced lung injury. In fact, the studies have this one study in 2011 where they measured the pressures in the nasopharynx, hypopharynx area. They actually showed that if the mouth is closed, there is a good pressure buildup also using HFNC, and this can be a useful tool. But and this particularly fluoride trial, which was published in 2015, randomized control trial between HFNC, conventional oxygen therapy, and NIV, showed that patients with non-hypercarbic acute hypoxemic respiratory failure with high flow of standard and non-invasive ventilation did not result in different intubation rates. So HFNC was as good as NIV or standard oxygen therapy. So there was a significant difference in favor of high flow oxygen in 90 days mortality. This was a retrospective observational study from 175 adult patients showing that early intubation and early intubated patient had better overall ICU mortality. This was published in 2015. This was interesting because they showed that failure of HFNC might cause delayed intubation and worse clinical outcomes in patients with respiratory failure. The PALIC 2 actually has told that the patients who are having possible ARDS or at risk of ARDS, you can give conventional oxygen therapy or HFNC. And when they are showing signs of worsening, then a limited trial of NIV should be used. And very close monitoring should be done for these patients, because there are potential harm of systematic use of NIV in parts, including risk of NIV overuse, intubation delays with prolonged instability, and patient self-inflicted lung injury when ventilator drive is high. So what is patient self-inflicted lung injury because of high driving? So if your patient is suppose on HFNC with severe respiratory distress and CPR hyperventilation, excess ventilator drive, alveolar pressure is suppose 10 centimeters of water. Because of excess ventilator drive, the pleural pressure swings will be going to negative pressure of as high as minus 15 centimeters of water. So if you calculate the transpleural pressure, it will be 10 minus 15 will be plus 25. So although your airway pressure is, you are thinking that your airway pressure is only 10, your transpleural pressure is as high as 25 centimeters of water because of negative intrapleural pressure swings when you are on HFNC mode. So that is why you need to be careful when you're applying HFNC. If patient is hyperventilating badly, it is better to apply some NIV and some positive pressure from above to convert this negative pleural pressure into positive pressure, or better intubate early and take over the ventilation. The other thing is the pendulum effect. That is in contrast to the normal lungs. The injured lungs do not have that fluid-like behavior, and hence, when patient is spontaneously breathing, there is a pendulum effect. That is the air moving within the lung from non-dependent to dependent regions, from one part of the lung to the other part, depending upon the time constant. And this also results in patients infiltrated lung injury. This was a study which was published in 2017 by Bellani et al. And they found it was basically a sub-study on lung safe protocol. And they found that 15% of the patients in that lung safe study cohort were on NIV with ARDS, irrespective of severity category. Although there is a clear guideline that NIV should be used only in mild to moderate ARDS, still even in severe ARDS, people were using NIV, and NIV was associated with higher ICU mortality in patients with severe ARDS. So what are the possible causes? One possible cause may be that PEEP. The severe ARDS patients need higher PEEP, and when you are an NIV, you tend to apply not that much PEEP. You can't apply, there is a restriction to applying a PEEP, higher PEEP on NIV. Those on NIV generated higher tidal volume, higher than 8.6 ml per kg, and NIV was independently associated with under-recognition of ARDS by the clinicians. This was again an interesting study in 2016, single center observational study. They showed that higher expiratory tidal volume was independently associated with NIV failure. They actually found that during NIV, the expiratory tidal volume results from the pressure support which you are applying during NIV, as well as the respiratory muscle pressure. And it was almost impossible to restrict this tidal volume to 6 to 8 ml per kg, because even if you control your pressure support, if the patient is hyperventilating, the respiratory muscles itself will generate higher tidal volumes. That is why the PALIC 2 has clearly said that even when you are applying NIV, you should be very closely monitoring the patients under direct physician observation in first 6 hours of treatment. Make sure if the patient is not hyperventilating, and as soon as you see there is any worsening in the respiratory rate, heart rate, increased work of breathing, worsening of gas exchange, then better to go for early intubation, particularly when there is hyperventilation and you are feeling that there may be a large pressure swing and excess amount of tidal volume and possibility of patient self-inflicted lung injury. Intubate early. The hypoinflammatory phenotypes also have been recommended very recently. There are some studies which are showing that when you have indirect ARDS, ARDS associated with shock or sepsis, multi-organ dysfunction, tend to have higher concentration of inflammatory markers as compared to hypoinflammatory. But the still no mechanical ventilation guidelines have included in their statements. That's why it is better not to discuss that as of now. But this is something which is already going on, and maybe in next few months or years we will get more literature on this. PEMVEC in 2017 has given lung morphologies: normal lung, obstructive lung, restrictive lung, that is a lung which is recruitable as in ARDS, mixed lung disease, chronic ventilation, lungs with cardiac diseases, and children with lung hypoplasia. And you can have a personalized ventilation approach depending upon what type of lung you are actually dealing with. So you can have a healthy lung approach, restrictive lung approach, obstructive airway disease lung approach, and mixed disease lung approach as per the PEMVEC guidelines. So to summarize, the use of CPAP should be conducted under physician oversight as per the PALIC 2 recommendation. Depending upon availability, you can use HFNC or NIV, but you should be very careful about what is the patient's effort. If you think that patient is hyperventilating with large pressure swings, possible pressure swings, or large tidal volume, or there is any worsening of the respiratory rate, heart rate, desaturation, you can shift from HFNC to NIV or from NIV to intubation. So this is important, and don't try NIV or HFNC for a very long time in patients with moderate to severe ARDS. The natural history of ARDS is basically inflammation, edema, lung increase in the lung weight, and compression reflexes. This is how a normal ARDS progresses. And when you intubate and ventilate, you are basically applying a certain mechanical power which augments all these things. It augments inflammation, edema, lung weight, and compression atelectasis, leading to more lung injury. And we already discussed in pediatric age group, we still don't know what is the threshold of mechanical power. So when you are applying a mechanical power, you ask whether it is a recruitable or a non-recruitable lung. If it is recruitable, lung pruning may benefit to provide more lung homogeneity, lower drying pressure and plateau pressure to deliver same tidal volume, less ventilator-induced lung injury. And if you have a non-recruitable lung, you may not have the chance of achieving lung, reducing the lung inhomogeneity, and then you may have to see safer plateau pressures and drying pressures how to achieve at lower tidal volumes. Because if you are applying higher tidal volumes and higher plateau pressures, then you will have chance of more ventilator-induced lung injury. So the lung injury will depend upon lung condition as well as systemic illness, prone positioning, neuromuscular blockade to reduce the patient ventilator asynchrony, appropriate PEEP titration, titration of tidal volume for available respiratory compliance, driving pressure, and biomarkers, as we already discussed, the hypo or hyperinflammatory ARDS, now the new thing which is coming up, we need to look at into more detail. And of course, extracorporeal membrane oxygenation also should be considered. This is the PALIC-2 guideline at how to intervene, and we can see the NIV is in very early stage. In moderate to severe ARDS, role of NIV is very minimal. Early intubation and ventilation is what is recommended. So once you diagnose ARDS, you go for a lung protective ventilation. The plateau pressure should be less than 28, tidal volume 4 to 8 ml per kg. Optimize your PEEP. Recruitment maneuver should be used only in carefully selected patients in recruitable lungs. It may not help all the lungs. When you are able to keep your plateau pressure less than 28, then you continue your ventilator strategy and monitoring the patient. If your plateau pressure is going above 28 to 30 centimeters of water, and you have a suspicion of poor chest wall compliance like obesity, pleural effusion, chest wall deformities, intra-abdominal hypertension, ascites, then you can consider transpulmonary pressure monitoring by esophageal pressure monitoring or electrical impedance tomography, and even measurement of end expiratory lung volume through nitrogen wash-in wash-out technique and measuring the strain and stress. If you don't have any suspicion of poor chest wall elastance or poor lung poor intra-abdominal hypertension, etc., and your plateau pressures are more than 28, then you can just continue monitoring the patient and ventilate the patient, and maybe even consider extracorporeal therapy, because there is a challenge to identify mechanical threshold for VILI, and it is likely that in some patients VILI is unavoidable due to the size of the baby lung, and the impossibility of safe ventilation is the rationale for resorting to extracorporeal life support like ECMO. Thank you very much.